Happy to welcome you to the Reaching the Unreachable webinar hosted by the Delivery Systems for Scale project through the Global Nutrition Clusters Technical Alliance. The webinar is being offered in 4 different languages simultaneously here. So all you need to do is click the interpretation button at the bottom of your screen, and you'll be able to access in English, Spanish, French, and Arabic. Next slide, please. So today during this webinar, we have an exciting lineup for you, and we're really going to be diving into how to reach the last mile, especially in disaster-prone and conflict-affected areas, through the use of mobile acute malnutrition treatment services. Next slide, please. This webinar working group, so the Delivery Systems for Scale project is hosted by UNICEF together with the International Rescue Committee, Action Against Hunger, and Save the Children. And to host the webinar, we've been working with the Global Nutrition Clusters Technical Alliance, which is supported by USAID, Irish Aid, UNICEF, and in partnership with the Government of Canada as well. Next slide. As you've heard me mention, the Delivery Systems for Scale project. This is a project that has run from 2022 into 2023, and we're just now concluding the end of that implementation cycle. We have focused on providing both technical and coordination support to support the scale up of wasting treatment in a number of high priority focus countries through generous funding provided by USAID's Bureau of Humanitarian Assistance, supplemental funding that was directed towards accelerating bringing wasting treatment to scale in 2022. During this webinar today, our goal is to highlight innovative approaches that we have used across the implementing partners of this project to extend the reach of child wasting treatment services to the last mile. Our goal is to share lessons learned across 3 different countries, the best practices that they've identified, and then encourage a really healthy discussion about what this means and how we can move the needle forward. Next slide. So for our agenda, we do have a packed agenda today. I will start out with the introduction of panelists. Then we will move into opening remarks. And we will have 3 different country presentations, starting off with Action Against Hunger Pakistan, moving to Save the Children in Somalia, and then finally concluding with International Rescue Committee's team in Ethiopia, before we open up to questions and answers. And then I'll have a few closing remarks for you before we leave. I do want to flag that you have 2 buttons at the bottom of your screen, a chat box. It would be great if you could introduce yourself in the chat box so that we know who is here and who's excited to hear from the country teams. But any questions you have, I want to encourage you to move them to the Q&A function at the bottom of your screen so that we can capture those during each of the different country presentations and make sure that we build them into the discussion at the end. Next slide, please. So in terms of our presenters today, you have 2 facilitators. You have myself. My name is Ellen Yakowenko. I'm the project director for Scaling Nutrition at the International Rescue Committee. You also have Eve Miro, who is the research officer in health and nutrition. She is working in Action Against Hunger's West and Central Africa regional office. And together we'll be facilitating different aspects of the webinar today. We also have opening remarks from Stanley Chitekwe, who's the Chief of Nutrition from UNICEF Ethiopia. And then we'll move to Dr. Fatima Amin, who's the head of the Department of Health and Nutrition and Action Against Hunger Pakistan. Then we'll have Aiden Yusuf Mahdi, who's the Senior Nutrition Technical Specialist with Save the Children in Somalia. And then we'll conclude with Jermaine Tizgaye Hal, who's the Health and Nutrition Program Manager at IRC Ethiopia. I do want to flag that we are having some of our presenters who are joining at a slight delay today. So in the interest of time, I do not believe that Stanley, are you here with us?
Yes, I'm here.
Okay,
I
perfect.
hear you very well.
Great. So Stanley, I hand over to you now to really set the stage for us and your opening remarks. Please go ahead.
Thank you very much, Helene. Good morning, good afternoon, good evening, colleagues. As you probably heard, my name is Stanley Chitekwe. I'm the Chief of Nutrition for UNICEF Ethiopia. I'm very delighted to be providing the opening remarks for this very important online seminar that seeks to learn from experiences and also identify how we can all more effectively reach children suffering from wasting who need treatment via mobile treatment teams. As you all know, there are an estimated 47 million children globally suffering from wasting, and a large part of these children are in disaster-prone and conflict-affected contexts, very highly challenging contexts in which we work. We also know that only 1 in 3 children with severe wasting receive treatment. This is not okay. All children with severe wasting deserve treatment, and we as humanitarian actors need to do better. Substantial work has been done to understand why children are not receiving treatment. Some of the factors include, number 1, a lack of understanding about available services. Number 2, limited ability to identify and understand when to seek treatment. And finally, lack of resources to travel to health centers, and also a very high opportunity cost at visiting those sites, as caregivers need to leave their household tasks and also other children and income generating activities. Distance to the treatment points often also plays a part in influencing the family's ability to access services, influencing awareness, cost, and time needed to access these critical services. These factors are actually made worse by disasters, especially flooding, and also insecurity and conflict, which actually make it an uphill battle for caregivers to access treatment for their children. In resource-limited contexts, with suboptimal infrastructure, often like roads and supply lines, and weak health systems and humanitarian community, including both local and international actors alongside governments, are obliged to find solutions because we cannot abandon children and women. Mobile nutrition treatment services provide an opportunity to respond to this challenge. Whilst not without their own challenges, they can be set up very quickly. They can also allow us to send these health workers wherever they are needed, supplying services to remote and often mobile or moving populations whenever needed. In Ethiopia, mobile health and nutrition teams, and we fondly call them MHNTs, unlocked new possibilities for us in the response to the Northern Ethiopia crisis, which started in November 2020, after conflict broke out in Tigray and then rapidly spread to neighboring Amhara and Afar regions. MHNTs, as we fondly know them, provided an unconventional service delivery modality because health facilities were damaged and most of the health workers were displaced. In the 3 regions, UNICEF and partners, including IRC, supported more than 150 mobile health and nutrition teams. In Tigray, these services often supported large populations of internally displaced populations. Without the MHNTs, thousands of children would have gone without treatment for severe wasting. Mobile health and nutrition teams as a concept was borrowed from programming in some parts of Ethiopia where we have pastoral communities, such as Afar and Somali regions. Through the mobile health and nutrition teams, it was possible to follow displaced populations, often underserved communities, and also we were able to supply both service delivery, but also at the same time carry out rapid nutrition assessments. In other words, the MHNTs provided a rapid response mechanism for nutrition in conflict. Health workers who had become IDPs became the core members of the mobile health and nutrition teams, thus bringing a wealth of experience and the ability to deliver services with limited training and limited orientation in a very rapid way. We will hear more about this from our IRC colleague later in this seminar. We are looking forward to hearing 3 experiences from Pakistan, Somalia, and Ethiopia. And I urge you to think about what made these experiences work for children and families, and how can we translate those good practices or even those experiences that didn't work to other contexts. As we all work to increase coverage and maintain quality services for the prevention and treatment of wasting, I think this is important for us to reflect on the best practices we are going to learn from Pakistan, Somalia, and Ethiopia. With these few remarks, I want to thank you.
Great. Thank you so much, Stanley. That teed up our conversation today very well. And without further ado, I want to get our presentations kicked off. Fatima, I hand over to you for Action Against Hunger, Pakistan.
Hi, thank you, Ellen, and good morning and good afternoon and good evening to the different colleagues that are joining us from around the world. I am here to present the breaching to barriers. Okay, I'm sorry. I think, Ellen, there is a technical glitch and I'm not able to move the presentation. Let me just try and reshare. Yes, I'm sorry. We are going to talk about how Action Against Hunger Pakistan formalized breaching the barriers to wasting treatment. To our colleagues joining us from around the world, a little bit background context regarding Pakistan. It is the 5th most populous country in the world, with an estimated population of 240 million as per the latest census. However, in the Human Development Index, we rank quite low, unfortunately, just 161 out of 192 countries. The under 5 mortality rate is quite alarming, with 63.3 deaths per 1,000 live births. A little bit background about Action Against Hunger, which has been operational in Pakistan since the massive earthquakes in 2005. And to date, it has benefited over 17 million persons. Action Against Hunger is currently operational. If you can see on the map at the southern part of Pakistan in the provinces of Balochistan and Sindh. To give a little overview about the situation of undernutrition in Pakistan, the last National Nutrition Survey was conducted in 2018, and it showed that nutrition is a public health emergency in Pakistan. The national stunting rate was over 40%, and the national wasting rate was over 17%, and it had a lot of provincial disparities, especially with Balochistan and Sindh being the most affected. And in Sindh, the wasting rates were exceeding 23%, which was quite alarming. In addition to stunting and wasting, we also have micronutrient deficiencies, with over 50% of children under 5 classified as anemic, and over 55% adolescent girls suffering from anemia, and similarly very high rates of anemia in women of reproductive age as well. In addition to this underlying situation of malnutrition, there were some additional stressors that I want to highlight over here. For example, the Afghanistan conflict, which resulted in one of the largest refugee movements. And currently, Pakistan is home to over 1.4 million registered Afghan refugees. And as per some estimations, there is an equal number which is unregistered. Of course, there was COVID, which caused a major impact on the annual GDP and the overall economic situation in the country. Pakistan is also unfortunately disproportionately affected by climate change. It is, as per the Global Climate Risk Index, it is the 8th most vulnerable country in the world to long-term climate risks, although it just contributes to less than 1% of global green gas emissions. As a result of this climate change, certain climate events happened in 2022, which resulted in a massive flooding, one of the worst floods in the history of Pakistan, which affected over 33 million persons and caused damages to infrastructure and agricultural land, livelihood. Just to give a context, over 1/3 of the country was submerged underwater as a result of these floods. We have insufficient government health systems to identify and treat the vulnerable communities, as well as economic insecurity, political insecurity, and inflation in food prices. Now, what did Action Against Hunger do in order to devise modalities for the immediate response? We conducted a rapid need assessment immediately post the floods, and we also triangulated the data from different rapid need assessments conducted by other development partners. And we analyzed the data as well as aligned our strategy with the Pakistan Flood Response Plan. And we identified the major barriers that were identified as for nutrition, access to nutrition treatment. We prioritized localization of response as per ACF Pakistan country strategy, and we tried to engage local partners as much as possible. In addition to that, specifically for the Afghan refugee and host communities, we conducted a detailed need assessment to identify the major gaps and needs and challenges in that demography. In response to the floods, ACF Pakistan immediately mobilized the nutrition treatment through mobile OTPs, and we also engaged the local communities to implement activities such as micronutrient supplementation and preventive measures for malnutrition, such as IVCF in emergency. We also integrated primary health care through mobile health camps, making sure that there is no duplication with other partners that are working in health and nutrition in the same region. And we also prioritized beneficiaries for our other interventions, such as for multipurpose cash grants. We prioritized households which were women-headed and households where there were children under 5. We have also integrated community-based management of malnutrition by establishing nutrition care centers at community health worker level, in which we identified community health workers engaged in health and nutrition interventions at the community level, such as, for example, polio workers and lady health visitors. And we established nutrition care centers where they are providing nutrition treatment from the vicinity of their household. In addition to that, we focused on integration of service provision for the Afghan refugees and host population. And for that, we did a lot of coordination with the local government and with the Commissioner for Afghan Refugees. And we prioritized healthcare facilities which were present in the catchment area of the refugee settlements, which were flood affected, which had gaps in medical supplies and human resource, and where there were no nutrition services present. After we selected these particular healthcare facilities, we embarked on rehabilitation of those healthcare facilities, as well as building the capacities of the healthcare staff. We also branched out into the communities by identification of community resource persons from the catchment population. And these community resource persons were trained, and they were basically doing the community mobilization, the screening in the community level, as well as referral to the healthcare facility. We also ensured provision of essential medicine, supplies. We established labor rooms or rehabilitated them where needed. And we also set up point of care testing at these particular healthcare facilities. After all of this hard work, we proceeded to start the provision of primary health care consultations, antenatal care, postnatal care, menstrual hygiene education, nutrition treatment, IFA supplementation, as well as mental health service provision, which included individual as well as group counseling from each of these facilities. Some of the major challenges and gaps that we identified along the way was the availability of trained staff for immediate response, which is very vital when it comes to emergencies, because when an emergency strikes, of course, there is no time to have a detailed capacity building of the actors present in those communities. There was also a lack of contingency supplies and pre-positioning of nutritional products as well as essential medicines, and the coordination at district level and lack of preparedness for response was another challenge that we faced. There was a lot of damage to infrastructure, including hospitals, including the roads leading to the hospitals. So that was also something for which was a challenge when it came to referrals, and we really had to mobilize most of the service provision and sort of worked on the substitution of healthcare services in these particular regions. Some of the solutions that we adapted were the localization and building the capacities of the local communities as an ongoing process prior to the disaster strikes, because ACF strategizes localization. So as a part of our ongoing projects prior to the flood emergency, we already had built the local capacities, we had identified community health workers, and we had a database of health workers who were working in the region. And therefore, it was easier for us to quickly mobilize our services in those particular areas and utilize those same community health workers which were trained prior to the floods for our response. And this is a strategy that we are also adapting currently, and we are trying to build the local capacities as much as possible. We also have framework agreements in place for nutrition supplies globally, as well as we have local agreements in place for logistics, which really helped us to quickly procure the supplies, as well as make the necessary logistical arrangements for setting up the mobile health camps, as well as the mobile OTPs. Another area that ACF really focuses on is to improve the local market for procurement in order to shorten the delays in international procurements. And we are supporting the conduction of GMP and GDSP audits for local manufacturers. We also make sure that we have initial as well as an ongoing coordination with district and provincial governments, as well as here at the national level, and we make sure that any other stakeholders in the area, such as other INGOs and local NGOs and CSOs, are also a part of the coordination meetings. We adapt a health system strengthening approach, and we make sure that we have a thorough coordination with the health department. And as needed, we can substitute, we can support, and we can strengthen the health system depending on the situation in that particular district. Some of the way forwards that we recommend are to strengthen the outreach and to implement family walk approaches, because once we stop our operations of mobile OTPs, of mobilization of healthcare services and nutrition services, it's important that early identification and early referral for malnutrition can be done by the communities. So we are really focused on building the capacities of the community and transferring the necessary skills and the necessary tools to the communities so that they can continue the screening for malnutrition as an ongoing activity even after the rollback of project activities. We also recommend placement of contingency stocks and anticipatory actions for community-based management of acute malnutrition, as well as capacity building of community health workers and the local partners and CSOs, because usually they are the ones who are present and are the first responders in case of a disaster or an emergency. Identification and strengthening of nutrition and emergency partners is another recommendation, as well as evidence generation for integrated interventions, because ACF has invested a lot in the past as well to sort of develop, generate evidence to make sure or to prove that nutrition-specific interventions are more effective when they are done in sort of coordination with nutrition-sensitive interventions. So, for example, when you integrate multi-purpose cash or you integrate wash interventions with nutrition treatment, there is evidence that there is a better outcome in those situations. So this is also something that ACF is really focused on and is really recommending. And that is it from my side. Thank you so much, and back to you, Ellen.
Thanks, Fatima. Great presentation from Action Against Hunger Pakistan. Please, everyone, remember, if you have any questions that come up during these presentations, add them to the Q&A box at the bottom of your screen. With that, I hand over to Save the Children Somalia. Please go ahead.
Thank you very much. I think you have all seen my. Do you see my presentation? Or
Yes, I see it.
do I want to show, or it is okay? Really?
It's okay. We can see it, Aiden.
Thank you very much. Hi, all. Good morning, good afternoon, good evening, all colleagues from around the world. This is Aden Yusuf Mahdi from Save the Children. As I'm working Save the Children as a senior nutrition technical specialist. To be honest, if I go to very briefly on the context situation in Somalia, is one of the most vulnerable, most countries that affected food and nutrition security in the global, as well as Somalia is the third country that has highest acute malnutrition children in the Horn of Africa. 1.5 million under 5 children are acutely malnourished, while 4.3 million, of which is 25% of the countrywide population, are facing IPC 3 and 4. So our medium GAM rate latest is 20.5 throughout the country, while some medium GAM rate is also 1.7. So to go with directly to the this presentation, I want to share with you that what Save the Children is doing in the areas that we are working. Save the Children is working in Somalia, 16 regions out of 18, and delivering high health, nutrition, and wash. Can you go up one time, please? Somalia is, as you know, it is a fragile state. Go down. Fragile state, limited infrastructure, conflict and insecurity, continuous growth, drought, floods, famine, displacement, climate issue, funding shortage, limited awareness on prevention, and poverty and unemployment. All these factors are surrounding us. So we are challenging on this. Go ahead. Thank you. To the next. For that reason, in order to at least address all those and reach the last mile, so Save the Children is doing CMAM integrated into primary health care at the facility level, as well as mobile nutrition team hard to reach areas where there is no health facility, which is very hard to reach, and also cannot be even constructed because of Somalia is always mobile. Normal people who are living in countryside or maybe rural areas, pastoralists are always moving and chasing after pasture and water. For that reason, if you construct a fixed facility, it will be a negative because they will not stay all the long time. So that mobile system is the best approach that we use. We also working with the communities. So for us to for them to have ownership of the program while we are the support of them. We have also increased family work, and we have trained all the caregivers that we are supporting. At the same time, not only we are also training female health workers who will provide ICCL, who then support those children with common childhood illness. At the same time, some mom treatment can be delivered at the community level, while even the mobile team are away to another location. So we also organize community-based IOICF programming. We have formed mother to mothers IOICF to father, because we are going to transfer the capacity to communities to screen their children as well as treat. Go ahead, please. Go down. So this is the best innovative approach that we come up to reach the last mile and how to reach areas. Increasing mobile teams coverage to the new accessible area. In Somalia, we have our government is having offensive fighting between Al-Shabaab. For that reason, always a new area is to be liberated from those separatist team who are the bottleneck of service delivery. Therefore, we always adapt and work with soon after the area become accessible, we will have to increase the mobile team. At the same time, we also have mommy care pathway, which is different kind of family-based mommy as well as facility-based mommy. In the community level, even we have trained female health workers to provide a mommy care pathway. Go ahead, please. So when we are dealing with the communities, we go with these steps. First of all, we do joint mapping with the community elders and agree where they are, where they want. We will, in order to increase the mobile teams coverage to the new accessible and hard to reach area, that will have empower communities and assign some of the responsibility to the community members, such as and recruit them, such as CNPs, distributors, scanners, registrars, to strengthen ownership of the program. After that, mobile team is composed, while technical team can be Save the Children will deliver there. At the same time, community also contribute. After that, community support the mobile teams, movement plan. They give us movement IL warning if there is a risk with the mobile team and the service delivery. Then we will do what kind of, it's called joint supervision with Save the Children, Minister of Health, community leaders, local authorities to make sure the programs are owned by all and also protected by all. Then we will do monthly and bi-weekly allocation of supplies to the mobile sites according to the target number and custody as well. At the same time, we do proper documentation of all supplies that we deliver. Go down. So in order to provide all this, we do real-time supplies monitoring. We also do constant support supervision and randomly perpetual stock checks. Also, we have the robust supply chain system, total inventory management system that captures all supplies movement from warehouse to the last mile. We do contingency planning is always in place in order to at least procure buffer stocks in order to respond if supply stock out happens always, because mobiles are most vulnerable. So we sign from the community, from the beneficiaries, what's called accountability sheet, because we wanted to make sure that the father or caregiver has received such supplies in order to recollect back the empty sites that we provided last week or before 2 weeks back. For accountability purpose, at the same time, we do ban all empty sites and empty cartons in front of the community committees in order to at least make sure that all the supplies went in a proper hand and it is used by the ultimate last mile of the children and also pregnant and lactating women. As Save the Children, 90% of our programs are integrated: health, nutrition, wash, FSL protection, and some were education as well. So while we are the rest, we will have to increase our integration. We also do what's called triangulation of monitoring tools. We do triangulate all the documents in order to make sure all the supplies children reach are equal and there is no totally what's called diversion. Go down, please. There's always challenge. Well, when we are delivering all this, we have these challenges: collecting and monitoring on-time data. It's in the remote area. It's a challenge. It took time, conflict, and insecurity. Sometimes when we are working as a mobile, sometimes some non-state actors can come and capture all this area. Then we cannot go there because of access. For that reason, that is always there. Limited infrastructure, connectivity in remote areas, also another that can hinder our functioning of mobile nutrition programs. The logistic transportation, because there is no infrastructure, there is no safe road, so that always logistics a challenge, and also supplies. You cannot do bulk supplies, you cannot store, therefore always a challenge. Then limited financial and human resource that can constrain as well the scale and effectiveness of our mobile programming. Therefore, expensive. That's so. Another one is the cyclical droughts, floods, which is in common Somalia, that are affecting the smooth running of our program implementation. Go down. To overcome these challenges, we do work closely with local authorities, communities to ensure safety and of staff and beneficiaries. We also do remote monitoring and partnership with local communities, and we also reach hard to reach communities and provide services. We also do regular support supervision with MOH team, real or meal team, to ensure the quality of services. We also do supply chain system, which we have, and train local health workers to maximize the impact of the programs while creating jobs in the community. Mobile technologies, sometimes somewhere we do where there is a connectivity, we have mobile technology that we can collect the data simply and reporting. Go down. Yes, these are the recommendations that we are providing. At least we need to, at least all of us, to conduct comprehensive assessment when we are doing a coverage of a mobile team to increase the coverage, in order to at least understand the specific challenges and barriers. And then after that, we will have to have well-defined strategy that outlines the objectives, target community, geographic coverage. And also then we will have to collaborate with the local communities and other healthcare providers to at least strengthen localization. Then they establish robust supply chain management system and implement comprehensive monitoring system. At the same time, we increase community health programs, ICCM and ICCM Plus, and also need to collect the feedback mechanism from community and give them back the feedback. Go down. At the same time, there should be an flexibility and adaptability. We have to be flexible, and we do flexible, because whenever we see there is a need, we go, because we don't go back to donor and say that some donors give us flexibility to move wherever there is a need, and adaptability and transition in certain programs. Also, we need to strengthen the local community's capacity, as well as the local authorities they have in order to contribute, and also integration of the mobile programs into the existing healthcare system for sustainability purpose. We also need to advocate for long-term funding, because always we are struggling and dealing with maximum 1 year, minimum 6 years, 3 months. We are in an emergency-prone situation. Therefore, it's very difficult for us to create an impact. Therefore, advocacy for long-term funding is paramount as well. We also need to document best practice, lesson learned, and success stories that we have seen, we have learned from. And also, we need to digitalize all the information system in order to at least have very robust information system. Go down. Yes, these are some of our mobiles. We are providing some kind of awareness session in the remote areas that we are working. Go down, the other one. This is also, we are providing support group sessions that communities are getting at a mobile. team, go down. And this is the OTB mobile team. They are providing nutrition treatment at the remote area, hard to reach area under the tree, as you can understand. There is no fixed or might be built. Thank you very much. And over to Elaine or Sanja.
Thanks, Adam. Thank you for that presentation. We have a number of really interesting questions coming in. Don't hesitate to hold them back. Put them in the chat box. We're prepared for a really good discussion, but before we do that, I want to turn to our last presentation from the International Rescue Committee in Ethiopia. Please go ahead. Jabane, do we have you on the line? While we try to check on his audio and connection, I think why don't we turn to the next section since we do have some good questions.
Yes.
Oh, do we have you?
Hello?
Hi, yes, please.
Yeah,
Go ahead.
yes. So this is Yamane from Ethiopia IRC, and thank you for the chance to provide me to present this important presentation. So Ethiopia is it's about 100 million population and facing with active war and hosting different IDPs. For example, more than 3 million IDPs here, and in Syria there are 200, above 200,000 IDPs, and we serving them with different local actors. So by saying this, the gum rate here in Tigray, according to the final retreat assessment, it shows 22% of gum rate is according to the assessment 2022, and the SAM rate is 3.4 and the MAM rate is 19%. When some of this 22% gum rate is showing in Tigray, Ethiopia. So when it comes to the introduction, IRC is providing life-saving service since April 22 here in Shira. Since the active one is escalating in northwestern Tigray. So we were starting the services in 15 warada. There are 15 warada in northwest Tigray, and so IRC was active by providing the life-saving service in those 15 waradas, and we were recruiting 6 MHNs. Those MHNs were comprising minimum 7 health staffs in each team. So we were providing in 15 waradas. 1 MHN was providing service minimum 2 waradas, maximum to into 3 waradas. So the MHN was provided, or the mobile health and nutrition treatment team was provided the service at non-functional health facilities and hard-to-reach areas. For example, outreach health posts. At that time, there was active war. The health professionals were not on their duty station, on their service areas. So IRC was the only active partner to provide the provide health services in that non-functional health facilities. Almost above 70% of the health facilities were not functional at the time, and we were providing the life-saving services by deploying the MHNT into non-functional health facilities. So by working, initially we were working 6 days per week, but after the conflict stop, we were scale down the days to 5 days per week. So thank you. Next, please. So in Tigray, the situation is very alarming, and the assessment shows from food security in June 2022, the gum rate is 29.4%. Children have wasted and 5.8% have severe wasting using by MOAC measurement. And more than half of the sampled one were males, and after 9 months, the prevalence was very increased, and it was very alarming. So the gum rate, the SAM rate, and the MAM rate, as you can see in the slide, 5.1% was SAM rate. The alert threshold, as you see, according to the WHO, it is under 2, but this shows 5% and above. So this was very alarming. The MAM rate also shows above 20%, and the threshold is less than 10%. This is twice of the alert threshold. The gum rate also, you can see 26, almost 27. So this is also the twice of the alert threshold. So this situation persists due to the existence of numerous interrelated barriers. For example, the supply barriers and the demand barriers. So we can see the supply and the demand barriers. So next, please. Next. Okay. When you see the supply barrier, this is related to the service provision and include location of services. For example, the service in Tigray were very unstable and hard to reach area due to the security, instability, the active war ongoing in that area. So it was very, very alarming and very challenging to reach that areas. And this was a very, very challenging, and the supply shortage, for example, supplies including the nutrition supplies, the medications, the medical supplies. So many supplies were not in and out from this country, from the country office, and from here there was no movement for almost 2 years in Tigray. So it was very challenging supply shortage, and the security itself, it was very difficult for us. We were not give active services, being the active war were ongoing in this area. So the other one is demand side. The demand side is when we see at community and at household level, it shows the ability to utilize the services, including distance to the service, the cultural preference. For example, one mother is coming with one child, but she may have 3 or 4 children in their home. They don't have any food to eat on their home. So she received for one child from ex-partner for the nutrition treatment, and she go back to her home and sharing and share and selling this for the sake of surviving the other children. This was very challenging for us. And the other one is education or awareness raising. In the previous 2 years, it was difficult for us to provide collective awareness session for communities. Due to the active war, there was drone attack. When we collect the communities, there was a drone attack at that time, and they may attacking all of the communities. So by fearing this, we were not providing the collective awareness. And the other demand side barrier is household resources. In the previous 2 years, all in all, the household or the Tigrayan peoples were not able to access their resources. They didn't have any resource in their hand, in their house. All government workers, they were not getting their salaries for more than 2 years, and this was very challenging, and it was very difficult for accessing the delivery of treatment. So this assessment was supported by the WFP food security situation in Tigray, as as you see in the percentage, 80% of household being food insecure. 13% only is maybe secured. This 83% of household being in Tigray is food insecure, and more than 4 out of 5 household consuming inadequate diet. So they consuming inadequate diets. Next, please. So selection of approach. In the previous 2 years, it was difficult to implement through the existing health services. So we sit together with our colleagues, with partners here, and with UN agencies, and set to criteria for the helping of the unreached individuals. The one is the mobile health and nutrition. The mobile health and nutrition is providing service to the hard to reach areas and at the non-functional health facilities by providing 5 days per week. And the activities were listed by my colleagues in the presentation, but some of the activities were provided by MHNs, were provision of primary health care, ANC service, PNC services, nutrition treatment, IYCF in emergency, and the system strengthening itself, system support or system strengthening itself. Some of the system support is are the training, on-job training, supporting of HMIs or surveillance. Those are the some of the system strengthening. And other, we also provide the rehabilitation of damaged health facilities. In the previous years, so many health facilities were damaged, looted. So as IRC, we were planning to rehabilitate those damaged and looted. Currently, we rehabilitate 4 health facilities, 4 or 5, 5 health facilities. And we were distributing so many medical supplies to those looted and damaged health facilities to revitalize their functions. So this is the emergency service. And the other is treatment of under 5 or malnourished children by going to the hard to reach area, by deploying MHNT, safe nurses, and by using local transports. For example, in last year, there was no any fuel in the town, in the region, and we have supplies at hand. So we face transportation shortages to transport the supplies for those needy peoples. So we were engaging the communities and participating local transports, for example, camel, and using donkeys, and discussion with the communities to have sense of ownership for transporting those supplies for the needy peoples by mobilizing the communities and appropriate for the local transport. So this was a very interesting approach we were selected by our side. The other very important was conducting last year Find and Treat campaign. Find and Treat campaign is initially it was designed for assessment. Unfortunately, the national government was not allowed to do the assessment for nutrition assessment, for example, surveys or others. At that time, it was restricted for assessment. So we need to sit with UNICEF, with partners. How can we reach those children? We don't have data. How much children are starved? How much children are malnourished? So by sitting with those partners and UNICEF itself, we create this approach, find and treat campaign approach, and we were conducting in 11 waradas, northwestern Tigray. So it was very successful. The approach was we were using the government health forces for the purpose of revitalize the systems, and we were incentivize them, and immediately after incentivize them, they start their work and giving the services in their respective areas. So when we do that find and treat campaign, we were screening 89 above 89 children, and of them 3,000 children were severe acute malnourished, and 17,000 children were acutely malnourished or moderate malnourished. So when we see the GAM rate, I mentioned in the introduction part, the GAM rate of 22, the SAM rate is 3.4, and the MAM rate is 1.9. This was the very, very important and interesting innovative approach here in Tigray. So it is a very, very important. And we were treating so many childs. Let me define find and treat. Find and treat. This is, you can find the child, immediately you can provide for 2 weeks or 3 weeks treatment. Then we hand over to the government and the health extension workers, the health workers to continue their treatments until they cure or started. So thank you. Next, please. So this is some pictures, some of the pictures during find and treat campaign. Those are very starved and emaciated children. Next, please. Okay. It is also using local transportation and community engagements. Thank you, please. Next. So some of the challenges, those are the very critical challenges facing in the last years: security, fuel problem, cash problem, supply shortage, transportation, and damage due to infrastructures, for example, health facilities, roads, and disorganized health system. The health task force were disorganized, and there is no system in place in each ward. So we were challenging this. And the communication itself, there was no telephone, there was no communication, banking. Those challenges were very, very obstacle for us to implement our service. Next, please. And we overcome some of the challenges. For security and fuel shortage, we were encouraging strong community engagement, negotiation, and resolve available local trust, as you see in the previous slides. For supply shortage, we prioritize the most affected people and IDPs. For cash, we create strong community awareness and engagement to build sense of ownership and share responsibility. This is somewhat overcoming the challenges. Next, please. Okay. We need to adapt the problems and fit with available structures. So where others we are doing this approach. So this is important. You need to adapt the situation, and it can fit with available structural government. The second is integration of programs. Different, for example, others we have several multi-sectoral activities and we integrate the services in the same area. For example, we have education, EVV, WASH, and we provide integrated approach in the IDPs, local communities, and we increase the size of the intervention sites as the emergency increases, and we also increase the size of intervention accordingly, and we need to ensure adequate supplies should be available. Next, please. So some of the recommendations are we need to deliver nutrition service require strong collaboration and coordination among governments, partners, and UN agencies. And the other is prioritize availability of adequate nutrition supplies in line with the number of actual target population. This should be available according to the target population, and WFP and UNICEF should work closely to ensure availability of nutrition families. WFP is for the TSAP for the mom treatment, UNICEF also for the son treatment. So we need to work closely and collaboratively to update those nutrition supplies. Next, please. Thank you. This is from my side. Thank you.
Great. Thank you. Thank you. Thank you for that presentation. At this point in our webinar today, we are going to turn to the questions and answers section. We've had a number of really interesting questions come in, and that Q&A box has been very closely monitored by my colleague Eve here. So Eve, I'm going to hand it over to you to facilitate the discussion among our panelists now. Please go ahead. Eve, I think we might have a problem with your audio.
Hello.
There we go. I can hear you now.
Does it work? Yeah.
Yes.
Yes, great. Sorry about that. So yes, indeed, a lot of very interesting questions. So let's jump right in. So maybe I would like to turn this first question to Fatima, to Pakistan. This is really about what was your approaches to maintain the necessary medications and RUTF supplies for the community-based health workers? And in such context where delivering the last mile is really the importance, what were the different actions and tips to really manage these delays, to maintain the supply chain of these essential inputs for service delivery? Fatima, please go ahead. What is your experience in this? Thank you very much.
Hi, thank you, Eve. A very interesting question, because this is something that I think all of us struggle with, to make sure that there are no breaks in the supply chain, and then there are no stockouts at the community health centers. So I think one of the measures that ACF took here was to sort of build the capacity of the CHW and the community health worker, not just in the treatment of malnutrition, but also in the logistical part of it. We provided them with the necessary tools to maintain their, the stock registers, and we also gave them orientations on that. And we also, as I said, are working a lot on building the local market, the quality of the local market for procurement of supplies in order to reduce the delays. So yes, it's an ongoing process, and it's it requires a lot of close monitoring and a lot of very close field visits and supervision, especially at the beginning of the setup of the community health centers. Thank you.
Eve, we're missing your audio again.
It should work now.
Yes.
Sorry about that. I'll try to find a solution to avoid this. But thank you so much, Fatima, for these elements. I think indeed it will be quite interesting to hear from the other countries. Maybe I wanted to know from Aiden, we had a lot of questions regarding training of community workers, the anticipatory actions for the implementation of CMAM, especially in place with the new WHO guidelines. Could you maybe go more in detail on how the community workers were trained? How were they used for the treatment? Were they able to treat those children, children affected by wasting? What was the experience? Could you maybe go a bit more in detail regarding the preparation and the training of the community workers? Aiden, from the experience of Save the Children in Somalia. Thank you very much.
Thank you very much. Yes, Save the Children has been working with this program of capacitating the female health workers, or it's some. In addition to, on other hand, I say ICCM program for the minimum 10 years somehow, so that during that time, female health workers were capacitated on yearly basis. They were, first of all, they have been selected by their level of literacy skills and their capacity. At the same time, they have been trained and they have been built their capacity. Therefore, they were providing only common childhood illness treatment at the community level, at the hardest to reach area. In 2019, we have started 2018-2019. We have started a global malnutrition initiative project, which is mostly was aiming to integrate female ICCM and include CMAM program to be included. To first of all, to be trained female health workers, how to screen, how to identify the children with acute malnutrition, with different kinds of it, some with complications and other complications. Therefore, we have done what's called pilot tests. We have done pilot tests in Somaliland, prototyping. We have been doing that prototyping up to 6 months. Then after we have finalized the prototyping and pilot testing, we noted that female health workers can afford to provide treatment of SAM and MAM with same product, only RUTF. Therefore, that's why we have capacitated the female health workers and started gradually wherever there is a need, where mobile team cannot reach, or there is female fixed site is not cannot be constructed, but female health workers can work for that area. Therefore, we have for 3 years we were working, developing tools, all the mechanisms that we can. How can we start female health workers treatment with acute malnourished children? Then, after we have done that and finalized the prototype, and now we are scaling that treatment of ICCM Plus in Somaliland as well as in Hiran region, where a lot of children who cannot access to go or to reach mobile, also might be female facility based, then those female health workers can provide. Therefore, that is as we are working a high number of regions, we are gradually increasing the capacity of female health workers at the regional level, wherever funds are available and accessible is there. So it is successfully we have seen the effectiveness. Furthermore, Save the Children and also working with University College of London, we are conducting randomized control trial. That is, we are investigating effectiveness of female health workers. How can they treat? How the impact will be? So that process is already started. Now we are in that process, and after hopefully when we finalize that research, randomized control trial, and the results will be shared widely in the countrywide as well as the global lessons learned and that innovation, the result and outcome will be shared with all of you. Anything if I left, please remind me. If we are not hearing.
Yes. Yes, you answered one of the questions, but I was quite interested about this the interaction of female health workers. Could you maybe go in more detail regarding how this will really build the capacity of those health workers, the female health workers? Can you hear me, Aiden?
Health workers or community health workers?
Female health workers.
Yes, female health workers. First of all, we do a proper selection when we assess their ability, their skills, how their literacy in that particular village that we are going to create a female health workers. Because we don't want to take someone which is from village A to village B. Therefore, we select the required people from that specific village or area that we need to start that program. Therefore, we do some kind of assessment. Therefore, the best of the best people we have to train. There's a curriculum, female health workers training curriculum that's set by the government. Therefore, we do follow that process and provide that training. After that, we will assess gradually and see how they are progressing, and understanding. Then after, they will go some kind of practical training. After all, they finish all this, and we assume that they can do their own. Then we again give another cascading training. From there, they can start the job. Yeah.
Okay, thank you very much. It was a very interesting question. I think it would also apply to the context in Ethiopia. So Yemaine, if you could see for this question regarding sensitivity in coming with these approaches, how was it integrated, and how was it integrated with other programs to become conflict sensitive in this humanitarian crisis, such as the case in Tigray?
Oh, thank you.
Elements for this. Thank you.
Can I answer the find and treat approaches? Yeah.
Yes, but could you also touch base on the sensitivity, the importance of conflict-sensitive approaches in these humanitarian crises?
Yeah.
Okay, great.
Thank you. As we humanitarians, we request to conduct assessments initially, but as a government, we are restricted to conduct the assessment. So we partners, IRC, UNICEF, and the Regional Health Bureau sit together. And we find solutions to find the unchild children. So we put find and treat campaigns. This find and treat campaign is important to find the children. Where are they? So important of the find and treats where one is to return for health workers to health facilities and to stable the securities. The other one is it's a good opportunity to improve the emergency nutrition response at that time, since there was no any assessment, security, access. So we need to find a solution. So this is a very big opportunity to improve the emergency nutrition. So the other thing is we need to improve the IYCF, the health promotions, and we were using the health task force by themselves, by incentivize them. So it was very effective. It was very manageable, and we were monitor them we were closely follow them. At that time, we deploy 2 or 3 IRC staffs in each waradas, so they were closely managed and conduct those financial campaigns. So this was a very important approach for us. The other thing is the exit. What are the exit strategies for mobile health and nutrition? I think the question, yeah. Can I answer that one? Is it for me the question? I think, yeah. The exit strategy is one is if the operational of that warada limitation of MHNT, for example, if there is no need of MHNT in that warada, it is one exit strategy. The other one is the health condition of that warada is, if it is improved, it is one of the exit strategy in place in that protocol. The third one is if the warada worsening than the warada having the MHNTs, it's one of the exit strategies. Those 3 main exit strategies we are using currently. So the other thing is the challenge we're facing for the management of acute malnutrition is, one is the supply side. I mentioned in the PowerPoint, the supply side in the last 2 years, there was no in and out. There was no transportation from the country office, from other sides. There was no flight. There was no communication. So those were very challenging to manage those acute malnutrition children. So the security also, the cash also, we were not paying, we were not receiving our salaries for, to be surprised, we were not get our salaries for 6-7 months. Me myself, I were not receive my salaries for the last 6 or 5 months. I get my salaries after 6 or 7 months, even it is 50%, 30% at that time. So it was a very difficult situation at that time. So this was very, very challenging. We were mitigating with the communities. For the supply shortage, we were creating an awareness and prioritize the highly affected and IDPs.
Okay. Thank you very much, Yemeni, for answering this question. We just need to give enough time for the other countries, as we have just a minute left. Thank you so much. I just wanted to come back to Pakistan. Fatima, your experience with the referral of MAM cases, or some cases medical complications, how was it put in place with other health facilities, and how was this coordinated? Fatima, thank you.
Yeah, thank you, Eve. So as I mentioned, that we really start with initiating the discussions with the district authorities for identification of even the intervention areas and the most high risk, or you can say the hotspots. So during our coordination meetings, we make sure that we are also working closely with the other development partners and humanitarian workers working in the area. So in our country context, we are working very closely with the UN organizations, as well as other actors working in nutrition. So in the beginning of all of our projects, we sort of do a mapping of, where to refer what and how. So when we have clear referral pathways established, it's very easy to sort of just pass on that information to our workers who are working in the field. And during our different coordination meetings, like for example, in one of our projects, we used to set up district liaison groups, in each of the district where we were working, in which all of the actors were called. And so we were able to, track the cases as well, and see if we referred one case, did that case reach the place where they were referred to as well. So yeah, it takes a lot of coordination and a lot of groundwork in the beginning, and it's an ongoing process as well, I would say. I hope I answered the question.
Yes, thank you so much, Tima. There were many questions as well for regarding the MAMI approach, and IYCF programs, especially for Save the Children, Aiden. So there were, let's say, a lot of questions regarding the implementation of the MAMI approach, the different, what kind of challenges that were encountered and the different lessons learned, but also how the community-based IOC program was put in place. Was it more about counseling, food demonstration, and what were the different strategies that were put in place regarding this MAMI? So, Agent, could you maybe go more in detail regarding this?
Okay.
Thank you.
Okay. Yes. If I start with the MAMI, Save the Children is the first organization started delivering a MAMI program of management of small and nutritionally at-risk infants under 6 months and their mothers. This program, we are working with areas or 8 regions that, thanks to BHA, USAID, supports us. But not all 100%, all the areas that we are working, it's not implemented by it. But this MAMI care pathway, it was one of the innovative, because the children, infants from 0 to 5 months in the remote areas, even and their mothers were somehow, they were lacking the support that they need. So that now we have that program from the BHA, and also another program which is supported by LDS, which is also supporting the community-based MAMI program. In the community-based MAMI program, we have also trained female health workers at the community level and given all the guidance and guidelines and IEC materials that as well as the tools for the screening, to screen the children, the infants and their mothers who are at risk. Therefore, soon after they identify some kind of IMCI as kinds of signs and symptoms, they may immediately refer to the closest health center if there is no pediatric hospital or maybe a stabilization center in that area. In that process, the health center, if there is a Save the Children staff who are dealing with the MAMI program, they will do another assessment. That assessment, they will recognize that the child, the infant is a low risk or high risk. If there's a low risk, maybe they will give counseling, the mother and the child. Otherwise, if the child and his mother might be high risk, they will have to at least do a referral pathway that we facilitate the referral mechanism. We have ambulance. If there is no ambulance, we can provide transportation for that family to go, and is being given to the referral slip to the closest health center or closest hospital or closest stabilization center, in order at least to address their condition with the mother and the child. After that, if the deterioration is continuing, the mother is being, and her infant is to be hospitalized until their situation is become normal. After that, they will be coming up to the facility, or maybe mobile or female health workers station as a follow-up up to the child becomes 6 months, and with his mother, where we provide counseling on that time. Therefore, the counseling and maybe assessment of the infant and his or her mother will continue up to that time. After that, if the child becomes well and good, the program will be discharged from the program. Otherwise, if there is still additional support is needed, we will have to refer in respective areas. If it is a specialist pediatrician, or maybe stabilization center that child needs support, and the mother if mother also if needs some kind of psychosocial support, mental health department. So we do that kind of process, and a lot of infants who were not receiving support before the program starts are now benefiting from the program, and the program is adaptation and understanding is good. Before, one of the challenges that we had before is Somalia management of acute malnutrition guideline was not capturing MAMI program. Therefore, now fortunately, the new WHO guideline is capturing all the MAMI program, so that now we have a very complete tools and complete guidelines and protocols. Therefore, we can cascade and we can still increase in the coverage of the MAMI program. Depends on the donor. Sometimes donors are give you some kind of restrictions, but BHI, thanks to BHI, is supporting us. On the IYCF, we have a community-based IYCF. Community-based IYCF, it is if there is individual counseling is being prominent, because then first of all we provide training to family or maybe lead mothers. Lead mothers will select caregivers, opinion leaders, traditional traditional healers. So we form every 3 months one team of female mother to mother support group or father to father support group, depends on, and it will continue at the community level. Yeah.
Yes, Aidan, sorry.
We do provide also demonstration, food demonstration, and how to cook, how to mix balanced diet that they can grow at their own locality. Thank you. I'm sorry.
No, it's thank you. It's very interesting. Sorry to I am sorry to cut you, but those are very interesting elements, and I just want to maybe repeat here that all panelists are available. That you will share their email addresses. You can email them if you have. There are many questions, unfortunately, that we did not answer today, and different discussions as well. So please feel free to contact everyone, and I'll give the floor back to you, Ellen.
Thank you. I do want to flag that the recording from this webinar will be available on the GNCTA website, as well as a written briefing note. And to the extent that we are able to, we will try to address the questions that we were not able to address in session here within that written briefing note. So please do follow up, and we'll make sure that you have access to those resources. Next slide, please. To close out, I just want to make sure everyone is aware that you have a wealth of resources at your fingertips. If you are looking for support for nutrition in emergencies, please do turn to the GNC Technical Alliance. They have in-depth support, both remote and in-country. You can hire a consultant directly through their roster, and they have a help desk available for quick technical advice on the spot when you need it. Also pushing you to NNet, which is a great resource for peer-to-peer support, and a number of other resources in this sector. Next slide, please. You can find the GNC Technical Alliance on the website that you see on your screen. Under the technical support option, you can request that technical support and other support that I mentioned, but I also do want to flag to everyone that we have here remaining. Under the latest portion of the website, we are having another follow-on webinar under the Delivery Systems for Scale project. It's scheduled for next week on September the 26th. Entitled Where Exceptional Circumstances Are Not So Exceptional. And with that webinar, we're going to focus on strategies that have been put in place both in Somalia and Nigeria to adapt the standard protocol for child wasting treatment so that it can be used in those specific emergency contexts, including discussion of simplified approaches. So that is the next webinar in this series that is coming up. Please do join us and register through the GNC Technical Alliance website. And with that, I would like to have a final thank you to all of the presenters for taking the time to share their experiences with us. It was great to hear from Pakistan, Somalia, as well as Ethiopia. And thank you as well to Stanley for his opening remarks from UNICEF Ethiopia. Please do take a few minutes to fill out the brief webinar evaluation that will pop up when you close this webinar. And thank you everyone who was able to join us. We'll have the resources available on the website. They will also be shared with you by email. Thank you for joining us. Thank you for taking your time, and I hope you have a good afternoon or evening. Thank you so much.
Thank you so much.